So let's talk a little bit about bone health today. I really got more interested again in this topic a year ago. We definitely have some limitations in terms of medications and how helpful those are, which is kind of what prompted me to do some more looking at this. So what do we know? We know that peak bone mass is achieved in our late 20s and to our 30s. We all end up with some gradual bone mass starting or loss of bone mass starting around age 40. Women experience an increased rate of bone loss in the first 5 years after menopause. Men tend to achieve higher overall density, but they also have a gradual decline as testosterone levels decline. Another interesting caveat that I want to throw in here is the concept of sarcopenia. And sarcopenia is a loss of muscle mass and strength. And it's often related to physical disability, poor quality of life, and death. Risk factors for sarcopenia are age, gender, and level of activity. This I want to relate to our bone loss based on activity we know, age we know, but also when we really start thinking about falls and those kind of things, I think it's really a combination of these things that we need to take into account. So this was a pretty cool graph that I came across. You can see bone mass on the vertical scale, age in years across horizontally. So the dotted line is men, solid is women. And so you can see how we peak our bone mass in following years out and then where we start to decline. There's also a lower line on there that you can see that talks about suboptimal lifestyle factors. So if somebody has a bad diet, they're not active, those kind of things, you will not achieve as high of a bone density to start. So, and that's important when we start testing, the initial test that we do sometimes, I would say it's more important that we get maybe 2 tests to compare or compare longitudinally over time, as that first test may put you in a lower range, but maybe that's the bone density that you've achieved in a life. So it doesn't necessarily mean that your bone density is declining. It just may be low. So we know about, positive impacts on bone density and growth. So lifestyle choices influence 20 to 40% of our adult peak bone mass. Common things that we know: vitamin D, calcium, exercise. These are things that we've talked about for a long time. The lesser knowns that I would say amongst a lot of practitioners and people alike, the role of magnesium, silicon, vitamin K, boron, vitamin C, copper, zinc, manganese, strontium. There's multiple of these things, as you can imagine, and which is what makes up all of our nutritional component. The other really important part of our bone health and our overall health, which we've been talking about for weeks now, is importance of weight bearing and resistance training. So all of these together, we know that they impact our immune system in a positive way. They also impact our bone density and growth as well. Negative impacts on bone density and growth: obviously poor nutrition does not help, inactivity does not help, smoking does not help, alcohol. There's medications that have negative impacts on bone density and growth. I think a lot of people are aware that steroids can have a negative impact. Oral contraceptives can have a negative impact. Antidepressants, seizure medications, acid blockers. There's numerous other medications that can have negative impacts on our bone growth. And this is a limited number. I have a multiple different references to relate in here that I'll be able to show you and talk a little bit about, what we are seeing. And some of these references are really great and, readable. So other questions about calcium, what we thought we knew. In terms of general guidelines, it's kind of been 1,200 milligrams daily for postmenopausal women, 1,000 milligrams daily for men. We're learning that it's more important to get these out of your diet in terms of dietary sources. and versus taking calcium, chewable calcium. We know also that if you get too much supplemental calcium and you don't have the other adequate nutrients, vitamin D, K2, magnesium, those things, we can actually potentially increase calcium deposition more in our arteries than our bones. So that's really important, and why dietary sources of calcium are so important. I'll run through this, but then I'm going to show you the reference that I provided for dietary sources of calcium, which is it's good, but it's also quite comical, and I'll show that to you. So obvious people know dairy, cheese, milk, yogurt. We certainly have fortified products in these categories too. Produce, collard greens, broccoli, kale, soybeans, bok choy, figs, oranges. There's lots of things that have calcium in them. Seafood, sardines, salmon, shrimp are good examples of that. And I already talked a little bit about dietary sources versus supplements. Let's talk a little bit about, what is osteopenia and what is osteoporosis? Like, how do we get that? Well, generally we do testing, and there's been some change in this testing, and it seems like it's kind of, it's fluxing a bit. So we've commonly done DEXA scan testing, and this has been the age-old thing. More recently, there's been some quantitative CT testing. I have not been able to find good data that the quantitative CT is so much better than the DEXA that it's worth the radiation dose. So, but there are definitely questions about both modes of testing. But when we do testing, we talk about something. There's two things we talk about. We talk about a T-score and a Z-score. And I want people to understand this a little bit. So a T-score is basically your bone density compared to a young, healthy adult of same sex. So this is commonly what gets used in postmenopausal women and older men being 50 in this case. And this is what we're defining if what is your bone density. So osteopenia being below average, lower bone density, versus osteoporosis, which is, are defined where we have more concern. And you can see normal is anywhere from +1 to -1. Osteopenia is -1 to -2.5. If it's less than -2.5, then you're in the range of osteoporosis. Another interesting caveat that we'll see often on your bone density score is your Z-score. In this, definitely Z-score, it compares you to an average person of same age and sex. And this is really important, especially if we're doing bone density in younger people, because you certainly, if you had to do one in a child, it doesn't do a lot of good to compare them to, an average young healthy adult, say 25 to 30. That's not going to compare. So Z-score really talks about that. I will show you then also this, another article. Let's see if maybe I can hyperlink to it. I can. So this article is really great and is actually one of, it's kind of what got me down this road, this in combination with an NPR quip that I'd listened to some years ago. But this article, which you guys will have a link to, I've found it's really readable, and it has actually one of the funniest cartoons that I think are kind of funny. This really talks about how here's like theoretically the drug rep guys down here, and there's 3 monkeys up in the tree, and they say, poor old guy just lost his grip. These guys look at it and say, looks like this unfortunate creature had osteoporosis. If only he had taken the proper medication. And so this article just talks about how, we need normal loading, that when people fall, is it your bone density that is that factor, that why you break the bone, or is it how you fell? And so there's lots of questions about why do we have fractures and that sort of thing. So that's interesting to me. I will, let's go back, we'll go back to this again. Whoops. And so that starts to lead a little bit into also kind of treatment options, you know, obvious treatment options that we know: diet and lifestyle choices, medications, bisphosphonates, selective estrogen receptor modulators, calcitonin, Forteo, Prolia, hormone replacement therapy. A lot of these medications and strategies are really around, you know, really focused around slowing bone turnover and slowing loss, really, rather than maybe building bone. The other options, which are actually really what motivated me, and there's a couple of different studies, one being the Combs study, which I want to go over with you guys a little bit, and I've written a blog about this before, but this is basically, it's called the, it's the combination of micronutrients for bone study, bone density. So an interesting thing that I wanted to be able to show you, so the Combs study basically compared just micronutrients. So the micronutrients being DHA, which is like when we have fish oil, there's EPA and DHA. So it has DHA, vitamin D3, vitamin K2, strontium, elemental magnesium, and dietary sources of calcium, along with exercise. So they compared this with several meds: strontium ranelate, alendronate, and risedronate. And you can see when you look at this table, like you can see 1 year on this, you can see the difference that you see with this protocol: 4% at femoral neck, whereas the meds 2%, total hip 3%, 3 to 4% best, 2% with alendronate, which is Fosamax, 4% at the lowest hip site. It's not calculated for the others. The spine, 6% here versus anywhere from 4 to 6%. So in this study, like, this combination of nutrients was found to be super helpful. The next study that I also looked at is basically called the MOX trial, and this is melatonin micronutrients osteopenia treatment study. This is a more robust study. It's comparing these nutrients to placebo. So it's a good study. This study, I'll link it for you. There's this is, I would say, a little bit more in depth for reading, but it's interesting because in this study they used melatonin 5 milligrams, strontium 450 milligrams, vitamin D3 2000 milligrams, so not crazy doses, and vitamin K 60 micrograms a day. And they were able to show, versus placebo, they looked at some bone turnover markers here, how much better people did with the supplements versus basically, you know, doing nothing, which is good, or standard American diet. So, and that they could show was related to improving this bone density. So going back to slides, it just really, and the other thing that they did is they did this health related quality of life indicator, and this was postmenopausal women, and their health related quality of life scores went up too, which I think is really cool. So it's just good for people to know that there are other options out there, because often I think we get into this situation and we get diagnosed with something, but then feel like we don't have options, which is not true, you know. So that's important for people to know. And then I will go, so basically these are my references here, and let's go to, we've already kind of looked at that there. This will kind of, so I want to show you guys the calcium rich foods. This is pretty interesting. So it's the National Osteoporosis Foundation. This is great. But it goes through different produce, you know, what is the estimated amount of calcium, which is awesome. Seafood, dairy, different things. and then this actually gets me, this is actually interesting to me. And then these are fortified foods. So, you know, waffles. Waffles are great, but I don't know that I would go for a waffle to get my calcium. And cereal, those kind of things. That's interesting. I was really particularly interested in these ones at the bottom, which I think you all appreciate. We are like trying to figure out how much calcium we get out of mac and cheese, which is a little bit comical to me, as well as cheese pizza. And so, you know, for what it's worth, there's plenty of different sources of dietary calcium, which, you know, are out there. The other thing, so I did, this is on our website, and so it's basically on the blog page. And so here's an article that I had written a year ago that you guys can reference, and I will reference back to this. You know, mostly eating a plant-based diet, getting good exercise, limiting tobacco and alcohol. It's kind of the same things we've been talking about again and again with regards to just health. And then another thing that I want to point out, and this is actually a reference in the slide deck as well, and I will reference it, but I found this really interesting. This was posted back December 21st of 2009. And it's a 22-minute listen, and it's really interesting about how it has to do with osteoporosis, osteopenia, the diagnosis, the drugs, and really like kind of how these concepts of osteopenia and osteoporosis really took off after they developed Fosamax. So I think most of you will just be interested in reading that, so, or listening. So for, you know, for what it's worth, I think people will be interested. So with that, I don't think, yeah, we looked at that. So hopefully, oh, good. Okay, so that kind of wraps up that, and I'm hopeful that you guys could actually see my screen unless I goofed that up at some point. So if one of you wants to let me know that, and I can always re-record that part. Question that I'm getting about collagen. And does collagen affect bone? I think, you know, I don't have any direct studies about collagen and bone. It certainly does help cellular function for sure. And really when we talk a little bit, and I don't know that I've actually talked about this or if it was just a blog that I had written about collagen and the extracellular matrix. And that might be something for us to review at some point. But collagen is really helpful because it really helps in terms of basically our cellular matrix is kind of the gel that holds all our cells together. And it helps create that fluidity within our cells and all those things. So collagen definitely helps there, you know. And I would say if we're helping from a cellular standpoint, yes, it's going to help with bone. But beyond that, I don't know if I can come up with another direct link, but I would say yes, it does help. Any more questions or? Good. So another comment is having had a DEXA scan and put on Fosamax and told not to exercise. Yeah, it is really, it's really interesting because I think back to, you know, over my 20+ year career, how we used to just say like, no, you need calcium. And I had a little spiel that I did with well exams, how much calcium you need pending your age. And that was really even before a time we were really even talking about vitamin D. And now we know there's all these other factors. And so, you know, you have to wonder, I have to wonder, you know, like how much has that advice, like how many people have we potentially accelerated atherosclerotic disease or cardiovascular disease with excess calcium, and it's hard to know. There are, calcitonin is brought up in here, and that actually, calcitonin can help, and that's a nasal spray, and it can help people, especially if you were to get a compression fracture in your spine. It can also help from a pain standpoint. So there's reasons for some of these medications, but really, just like any medication for all of us, medications can help us, and they have their appropriate place, but really, lifestyle and nutrition and all of those things are so much more important than a medication, because especially when we kind of start to look at, when we look at any disease, I was doing some more reading about herbal remedies and the role herbal and botanical nutrients, whatever you want to call them, play in impacting our immune health and COVID. And it's really interesting because with in the drug world, we've kind of tried to take one pill for one ill. So we take something with the thought that, oh, this only impacts this. And then when it does anything we're not expecting or anticipating, we say, oh, that's just an adverse effect. Well, it's not necessarily it is maybe adversely affecting you, but it's just another effect versus just a side effect. And so it's really interesting when we think about that, because when we do take other nutrients, and the two studies that I outlined here really talk about, it's the combination of things. And that's why getting dietary sources of calcium, there's other things happening there, and probably not in fortified waffles versus broccoli, but there's other things that are happening there that are allowing those nutrients to provide us more. And that's the part that we're kind of missing the bus on when we talk about just pharmaceuticals alone. And I think that also is inhibiting our ability to get good studies, because there's often pushback, like there's no data for nutrients, there's no data for these different things. Well, it's really hard to pull apart every component of broccoli to figure out, what's impacting what. I mean, they certainly try to do that, but also with the understanding that there's not money in those studies, if you will, because nobody's going to make that drug unless they can try to make a portion of it, which we see happen all the time. A lot of our modern medicines are derived from plants. So it's just interesting that I feel like we're starting to see a bit of a turn, if you will, certainly with all of you understanding the role that nutrition plays. And I think, it's not so common for me now to have conversations that people really don't understand or appreciate the impact that food is having on how they feel. And I think in general, a lot of times people really don't have a good grasp on what food does to them and how it makes them feel and how it impacts their sleep and energy levels and all that. But I think, slowly but surely, people are starting to understand that. So I think that's great for all of us, really. So, other questions or comments? Good. Looks like we're good. So we're headed into Memorial Weekend. Everybody, please be safe. We still have a burning ban here. We don't really need fires that will just negatively impact our air quality, which will not help any of us. And so if you're around in the neighborhood, come get your neck gaiter. And otherwise, we will, I will get a newsletter out. I think we will take next week off on Thursday, and we'll have a meeting the following Thursday. I am planning to virtually attend the Institute for Functional Medicine annual conference Thursday, Friday, Saturday next week. So I will not talk on Thursday. And if that changes, I can send out a message real easily and update you all, and we can't jump on a call. So So with that, everybody have a happy Memorial Day. Be safe, and I will see you in 2 weeks. Okay? Thanks, guys. Have a great day.